Bismillahirrahmanirrahim. Assalamu alaikum warahmatullahi wabarakatuh. Dear chairpersons, dear colleagues, it gives me a great deal of pleasure to be talking to you today about evidence-based indications of echocardiography during TAVR. From what we've gathered from Dr. Faisal's discussion, we've very quickly realized that pre-procedural planning is key to success of any interventional procedure like TAVR, and predominantly, that's fine, sorry. Okay, and predominantly the use of CT and TE pre-procedure. And as Dr. Faisal mentioned earlier on as well, doing transesophageal echo peri-procedure or intra-procedure is going slowly out of fashion. So I'm going to play the devil's advocate and try to show you some of the evidence in favor of using transesophageal echo intraoperatively. I have no disclosures pertinent to this talk. Just as a quick outline, I'm going to very quickly go through what needs to be done from a pre-procedural point of view from an echocardiography perspective, some of the minimum data sets that are required before we decide the patient is going for TAVI, and then go through the intra-procedural findings that are warranted to look for when you're doing a transesophageal echo, and then we'll wrap up with a quick summary and take-home messages. So pre-procedure, as was mentioned earlier on, transthoracic echo and transesophageal echo are vital as a starting point. The minimum data set that you require is the following. You need to make sure you clarify the etiology of the valve stenosis, the morphology of the valve, the severity of and the degree of the stenosis. What is the function like? Do you require low-dose dobutamine in these cases? And what's the myocardial thickness like? Is there septal hypertrophy, and how significant is that? And finally, very importantly, are there any other associated lesions like valvular lesions? So when it comes down to morphology, again, very important to highlight whether you're dealing with a bicuspid valve, a calcific valve, or a rheumatic valve. And from an echo standpoint of things, because I know most of our target audience here are echocardiographers, you need to make sure that you use multiple views, short and long parasternal access views, to make sure that you describe the number of cusps, the thickness, the mobility, and the degree of calcification, as was mentioned earlier on. Now, severity, we know, again, as per the guidelines, there are three major data sets to define what's severe aortic stenosis, looking at the jet maximum velocity, the transvalvular mean gradient, the aortic valve area by continuity equation, and my favorite is your dimensional velocity index or velocity ratio. And for you to do that, obviously, you require a number of images, like a CW across the aortic valve, a PW across the LVOT for the LVOT VTI, and the LVOT diameter. And it's important, again, I'm not going to go through the technicality of this, but it's important when you do that, for instance, the aortic valve gradient, to look at it in different views, so using the suprasternal and the right parasternal to make sure that you get the most accurate gradient. Similarly, when you're doing the LVOT VTI, look at the right side, try to get the perfect alignment with your sample size to get that beautiful triangular shaped Doppler, and to get a good definition for your LVOT diameter, because you're going to be measuring from inner edge to inner edge. I would advise the echocardiographers here to be referring to this document, which is published about a couple of years ago, and it's a document that describes the technical aspect of how to measure or estimate and grade aortic stenosis, and it's a combined effort between the American and the European Society of Echocardiography. So what is low flow, low gradient aortic stenosis? It's when you have a low valve area inconsistent with severe aortic stenosis, but your gradient is discordant to that. So your gradient is lower than expected, and you have a low ejection fraction. Here, you need to entertain doing a low-dose dobutamine stress echo to make sure that you identify whether this is true or severe aortic stenosis. More importantly, in the pre-procedural study, you need to ascertain whether the presence of MR. based on a number of studies, about 3/4 of the patients that are considered for aortic valve intervention have a concomitant mitral regurgitation. And it's vital to have an adequate and a thorough assessment of that MR pre-procedure. Now, why is that? Again, as I've mentioned, 3/4 of these patients would have, up to 3/4 of these patients with severe aortic stenosis would have some degree of MR. And from this meta-analysis that was recently published, about a fifth to a third of these patients would have moderately severe MR. And when you do have MR, one thing again to highlight is what's the etiology of that mitral regurgitation. So is it primary or is it secondary? And from this meta-analysis as well that was published, clearly most of these are secondary MR. And the reason why that's important is because secondary MR usually gets better after TAVI. So why is all of this important? It's important to predict outcome in patients who are undergoing the valve TAVR, because as was highlighted here, the more severe, moderate to severe forms of TAVR usually get better. So you can either get improvement of the mitral regurgitation, no change, or worsening. Very seldom do you get worsening of the mitral regurgitation. And if it is a secondary form of MR and in the moderate to severe form, they usually get better post-procedure. And this is again another forest plot that looks at the mortality of these patients. So although they do get the degree of mitral regurgitation gets better, yet their overall long-term outcomes are not as well as those with less significant mitral regurgitation. So intraprocedural echo is used as a monitoring tool, and I know it's coming out of fashion, but I would try to argue against it because it gives you good feedback intraoperatively, especially when you're not doing high volumes. It assesses prostatic valve function, and it gives you a quick and rapid detection of complications after the ballooning or after putting in the transcatheter heart valve deployment. So what are the different components that TE can help during the procedure? Well, it can help. It's sometimes difficult to pass a guide wire retrogradely through a very narrowed, stiff valve. So it can help to give you real-time data when it comes down to positioning of this guide wire with using an X-plane, simultaneous imaging, the long and the short axis views. And also can see the tip of the coil, which is also seen in fluoroscopy, but it can show you as well more robust data on the stability of the tip of the wire as well. During the balloon valvuloplasty before TAVR, during the balloon valvuloplasty, TE can be useful to identify post-valvuloplasty aortic regurgitation and in the presence of cardiac tamponade. Immediately post-deployment of the transcatheter heart valve, the TEE can play a very important role in giving you an accurate assessment of the valve position, the shape, if it's oval and it requires further expansion or ballooning, leaflet motion, whether there is a significant increase of the pressure gradients, and what is the effective orifice area as well. Again, as was mentioned earlier on, it can be useful to highlight whether you have transvalvular or paravalvular aortic regurgitation immediately after the valve deployment. And transvalvular regurgitation could be simply because of the wire placement. So it can guide you and tell you, well, try to remove the wire, and then the degree of aortic regurgitation will significantly reduce. Now, in other cases, as was mentioned, a paravalvular aortic regurgitation is kind of difficult to assess, and it's quite challenging to assess, especially for people that do TEs in the OR. It's very different looking at it than when you're looking at your conventional TAVR patients with a sewing ring. You have to actually rotate the TE medial to lateral to try to unmask the degree of aortic regurgitation, as is displayed in this image. So if you look at the image highlighted as E, you may not notice significant aortic regurgitation, but the slight movement can show you, as is seen in D, a significant degree of aortic regurgitation. So why do we worry about aortic regurgitation? Because it is very much correlated with worst outcomes. So the more severe the aortic regurgitation immediately after deployment, the worse the overall outcomes. And this has been noted through multiple meta-analyses and studies, all of which, if you can see through this forest plot, all of them pass the line of unity in favor of increased risk with more severe forms of aortic regurgitation. Now, why do we get aortic regurgitation? The number one reason here is undersizing of the prosthesis. And there is a nice trick that you can use, which is basically called the prosthesis annulus cover index. It's a calculation which is basically the prosthesis diameter minus the TE annulus diameter over the prosthesis diameter, and you multiply that by 100 and you get a fraction. And if that number, that numerical value, is more than or equal to 8%, the chances of you having severe aortic regurgitation is low. But if it is less than 8%, you're more likely to develop aortic regurgitation. So that is another finding and another calculation that you can do using your echocardiographic findings. Other complications that you may encounter is mitral valve damage. And so you have to always, while you're doing the procedure, monitor the severity of the mitral regurgitation and look at the anatomy of the mitral apparatus. Pericardial effusion can indicate localized bleeding during the procedure. So when you do pick it up with a TEE, you have to do a number of things. Look for the physiology, whether it's in keeping with tamponade, yes or no. Why is there a pericardial effusion? Is there a chamber perforation? And look for aortic dissection as well. As was mentioned earlier on, CT is now being a more robust tool to predict the likelihood of developing any coronary occlusion, but as well as that, TE can provide real-time data during the procedure to look for regional wall motion abnormality that may result from obstruction of a coronary due to a displacement of calcification in the coronary ostia. So you can assess the blood flow in the coronary ostia using the color Doppler. Lastly, just a couple of more slides, we're going to be looking at aortic rupture or dissection, which again could occur. So the things that you should be looking at is the presence of periaortic hematoma or aortic dissection. So in summary, dear chairpersons, dear colleagues, echo is still an integral, obviously echo has always been an integral component in TAVR, but it still has a role intraprocedurally. In the pre-assessment, you assess, as we said, morphology, severity, and calcification, along with other associated lesions and LV assessment. But during the procedure, it's quite useful to help guide with wire insertion, balloon valvuloplasty, ST, positioning of the valve, and looking for immediate complications. Thank you very much.
Good afternoon, everyone.